work-related asthma, so it's going to be a brief review. But just as a background, as an aside, I'm also involved in a project on work-related asthma. It's an educational project in the province, but it's funded by the Ministry of Health and Long-Term Care. So it's really interesting. It's sort of, I think all of us in the room are occupational or have a work-related aspect to what we do. Well, this is seeing the other side of the fence, and it's all health-based. So it's really interesting coming as the occupational person into that environment, and it's been a real eye-opener. So the point of the project is to educate anyone on work-related asthma. And so the audience will be either healthcare typically or workplaces, so we do everything. And you see completely different perspectives from both of those things. So the healthcare people, when we approach family docs or respiratory educators or nurses or those sort of groups on this message, they say, well, that's interesting, but we have a lot of things to cover, and work is a small thing, so they don't appreciate the role that work plays in causing this. So it's a constant battle to get those audiences, because work isn't a big issue, and we sometimes forget that we're so immersed in work-related stuff, we forget the bigger picture of health, that's a huge elephant, and that they only consider work transiently or a small proportion of issues. And of course, the other part is approaching work-related audiences, so workplaces, unions, those sort of things. And of course, they're very receptive to a message on a work-related disease like asthma. But the thing is that they don't really have the educational infrastructure, so the place we struggle with that is finding the audiences and finding places where they come together as a group to educate them, so they want the education. So just as an aside, that was just the experience that we have in sort of propagating or perpetuating some education or recognition on a disease. Is it this one? Okay, so 15 minutes on work-related asthma. Just as a background, one slide. So what is asthma? You know, when we breathe, we've got tubes that bring our air to our chest. Well, in asthma, what happens is those tubes get tight. It's inflammation and it's constriction. So the tubes tighten up, so the air is not getting to the lungs. It's an obstructive lung disease. The interesting thing is it's paroxysmal, so it's not there all the time. So sometimes you're fine, sometimes the airways tighten up. The other interesting thing is that it's often caused by exogenous factors. So there's something that causes that to happen, and it's usually a hypersensitivity. So people are often allergic to something, and that's manifest in the lungs as asthma. The implication of that is it's sort of this predilective type of health effect. So if I work around isocyanates and I'm not one of the people sensitized, I will have no problem, whereas there's the 5% that are sensitized to it, and they're going to develop a disease. So it makes it difficult to sort of regulate things. Some people will have no issues, others will. And it makes it further very difficult, and I'll touch on it a little later on, to understand what levels are safe, because the implication of the hypersensitivity is that if you're allergic, it can be very small or minute levels of an exposure that can cause a problem. It's very fascinating from our perspective in the health world. So what is work-related asthma? Well, there's a couple things. Classically, it was called occupational asthma, but there's also this entity, work-aggravated asthma. So I've had asthma all my life. I go into workplace, it makes it worse. So that's the other piece of it, and that is compensable in Ontario. But mostly we think about this one, occupational asthma. That's people that have never had lung disease, but you go into a workplace, you start working around some sort of exposure, your lungs get sensitized, you get this allergic reaction, develop this asthma. Most of the time it's this, so it's a true allergy to something in the workplace, but I've also written in small font this irritant-induced one, and that's a rather rare one, but it's really interesting. It's sort of an acute spill to a large amount of irritant seems to induce an asthmatic response. So the epidemiology, it's interesting, Lynn's slides are almost completely analogous to these, and it's the same conclusion at the end of it. Incidence is the occurrence of new disease, so it's a way of looking at the temporal patterning of disease, and it's very hard to measure, so you have to follow people over time and see. So there have been a number of studies that have tried to estimate the incidence of occupational asthma in societies, but you can imagine that if things aren't reported, or if there's not an adequate database of evaluating this, that they're going to be rather inaccurate. And this slide sort of reflects that. If you look at the various incidence data, they're quite variable, aren't they? It's either reflecting that there is true variation in the incidence across jurisdictions, but more likely it's just indicating that they're measuring different things, that there's some sort of error in the measurement of that. So you can sort of ballpark the incidence, but perhaps more importantly, just get a gist that it's very difficult to measure that. That is the occurrence of new disease. I'll just skip over these for time. And there have been attempts to set up such a database in Ontario. So this is a report by Toe from Sick Kids about the development of a work-related asthma database in Ontario. So that was going a number of years ago, and they recruited a number of us to try and report all the new cases, that is the incidence of work-related asthma in a given period. And this paper just described that. Generally, there were very few cases reported, so I can't remember exactly the reporting time, but 34 cases of occupational asthma and 29 of work-exacerbated asthma. Likely, if you do the modeling, it's far less than what you'd expect. And essentially, they concluded that it seems feasible to develop a voluntary reporting system, but the long-term sustainability is questionable as well. The validity of the results was questionable as well. In other words, it's really hard to measure this stuff. An easier measure is what's called prevalence, and that's just one snapshot in time. So if you ask all of Ontario at one moment in time, how many of you have work-related asthma? You can get a better sense of, not a better sense, but you can get perhaps a more accurate measure of what the occurrence is at that one moment in time. The problem with prevalence is it's only telling you that one moment and doesn't give you an indication of what happens over a time period. So it's just not as good of information. And this is just a quick review of some of the papers. There's lots of papers that estimate how much asthma they think is in certain societies. And again, you can see the numbers vary quite considerably amongst those. If you sort of triangulate the data, this was a larger paper, again out of Europe, that has better surveillance system as a prospective surveillance on work-related asthma. And it looked at quite a number of people. The bottom line was an estimation about 10 to 25% of asthma in adults seems to be attributable to work. So almost a quarter of asthmatics might have a work-related component. And that 10 to 25% is sort of where we are around now if we try and, if we have to throw out a number as to how much might be related to work. So that's a summary. Is that a lot? Well, it depends on your perspective. The 10%, 1 in 10, 1 in 4 perhaps. Not a huge number, but as well consider the denominator, and that is how many people actually have asthma. So asthma is one of the most common chronic lung conditions, and the prevalence in Ontario is about 8.3% in adults, or at least those 12 or over. So that's not a small number of asthmatics in the province, and then you multiply that by the 10 to 25%, and you can do the modeling that Lynn was showing for the dermatitis similarly, and try and get some sort of estimation of how many you might expect in the province. So it's not an overwhelming number, but it's there, and 8% of adult population is something. And we know as well it's been increasing over time for various factors. So it should be of some importance. And then again, Lynn was showing us the same slides, but we can try and determine, well, is this reported? Is it being recognized by people? And this was a study out of Toronto, and it just looked at reporting of work-related asthma in medical practice. So length of time from symptom onset to reporting of symptoms. So it took about half a year for a patient to recognize that they're getting symptoms and report this to somebody. And then it took an average time of 5 years to get a diagnosis of work-relatedness. So you can see there's quite a lag between recognizing the disease and then recognizing the work-relatedness. And sort of exploring some of the factors that delayed that. Physician did not ask about work-relatedness 40% of the time, which is really a problem, and that's partly what we need to address, and some of the other factors as well. These are similar studies, almost the same thing. So only 14% of asthma patients discussed with the doctor the role work may have played in contributing to that. We need to get that way up, and again, that's some of the work in discussing with the healthcare world that work may be an important determinant. And again, a big delay from onset to reporting. So summary of all of that, how much asthma is related to work, about 10 to 25%. And we know it's unrecognized, so there is a big burden out there, but if we use the WSIB stats, we did a similar sort of exercise and tried to obtain WSIB, and it's really just a fraction of what might be estimated or modeled as far as what's out there. So I'm just going to go over a few slides about prevention. I really culled down, I'm not sure if everyone has access to some of those papers that we did, but they sort of summarize all the action points and the framework that Lynn discussed. I'm going to sort of more do it as tertiary, secondary, and primary, if you understand those terms of prevention, and just touch on some of the highlights to cull down some of the information. Let me just slip through the animation here. So I'll start over here. So this is the worst area of prevention. This is tertiary prevention. The person has the disease. Now we're just trying to minimize the impact or burden on their health. And that's the medical world, isn't it? So the person's already come to me with a diagnosis of work-related asthma. And that's, okay, how am I managing it? How do I treat it? A couple issues with that. So in tertiary prevention, one of the biggest problems is that we're not even recognizing it. And that's the diagnosis piece of this. As physicians or healthcare, we're very good at diagnosing asthma. It's very objective testing. You give the person, subject the person to spirometry and just measure that. We're not very good at doing this step though. So we can identify the asthmatics, we don't ask about work. And it's questions like this. So whose job is it or whose responsibility is that to identify that work-related piece? And really it's actually such a small thing that needs to be done. Someone just has to trigger in their mind, hey, maybe my asthma is related to work, but unfortunately it doesn't often happen. And there's of course a number of touch points that could happen. Could be the health professional. So the physician should be aware and should be asking all their adult patients, what do you do for a living? But we know that doesn't happen. It could be the patient. The patient should be coming to the physician with information to say, yeah, you told me I have asthma. Do you know I work in a bakery? And we're not sure that always happens as well, because patients won't know about that or don't completely understand work-related asthma. Might be in the workplace as well to equip the patient with that information. So there's a number of points that should be addressed, and that was talked about in the position paper that I did. I just wanted to highlight this study, and this is an attempt to try and educate the healthcare professional about work-related asthma. And one of the more contemporary ways we try to do that now is integrate questions into an electronic medical record. So when you're at your family doctor's office, you probably see them now typing away in the computer most of the time. Those things have flags in them, and so people have tried to incorporate flags into EMRs to try and trigger questions about work-relatedness. So if someone's identified as asthmatic, then the computer should pop up and say, hey, ask the person about what they do for a living. And this is a study that has just looked at the incorporation of a questionnaire like that. So what happened was the doctor would go in, the person would be identified as asthmatic, and the 14-item questionnaire would pop up and walk the person through and would ask, what do you do, what are your exposures, etc. So this study looked at that. Very small sample size, so it's very preliminary. And bottom line is it was rather effective, of course, at identifying that work-relatedness might be an issue. The problem with it was this, that it's difficult to incorporate, that EMRs varied across the province, and it took a lot of resources to try and push this thing into it. So it's a very elegant and interesting solution to a problem of recognition at the physician level, but there's certainly significant challenges in incorporating that, and that's what that spoke to. So moving a little further on, so recognition is a big one. And recognition, of course, there's a huge role for the workplace and for the worker side of it to recognize things. Now moving on, so management. So the person's diagnosed with work-related asthma. Just briefly, if someone is truly sensitized to something in the workplace, that is they have occupational asthma, they need to be removed from that exposure. And it's quite a profound thing to say to somebody, and it's not something we do lightly in the occupational world, is to remove someone. You often are trying to mitigate their exposure or engineer them down. Well, that doesn't typically work for a sensitizer if they truly are allergic. Just note that the other two, they can stay in the workplace. Skip over that. The implication for both the recognition and the management is the longer we leave them in the workplace festering, the worse their condition is going to get. So if I don't recognize that the person coming in has worked in a bakery and they keep working and keep working there, their condition will get worse and it will become permanent. So when we eventually remove them, there will be no alleviation of their symptoms. So it's just the bigger problem of dealing with that. I didn't review all the literature, but there was there is a good systematic review that was done a number of years ago looking at the outcome of this. basically what it's saying is when you look at rates of recovery, it's only about 32%. It's sort of a composite outcome, but generally just understand that this is expressing the fact that recovery of work-related asthma is really quite dismal, that people do very poorly in this. And it emphasizes the point that tertiary prevention doesn't work. So if you're expecting the medical world to identify work-related asthma and then cure these people, it doesn't really happen. The person typically has fairly established disease that doesn't get better. This is an interesting study, and again, speaking to somewhat to the futility of tertiary prevention. It was a UK study, and they followed people with work-related asthma. Kind of a busy study, but basically what it says is that people would actually choose to continue to work in the work environment and maintain their income and accept a decline in their pulmonary function as opposed to going off work. And it's a challenge we see all the time in clinical practice. If I see someone with work-related asthma and I tell that person, you worked as a welder for 20 years, now we identify you have a disease, you can't do that job anymore, usually the next thing is that I never see that person again because they don't want me to give them a message that they can't do the work. Imagine me telling you, you can't show up to work tomorrow, we'll find something else for you. So it's a big issue as far as the tertiary aspect of prevention of disease is what do we do with these people? And part of it's in the WSIB system of retraining, but there's a lot of work to be done in all aspects of that. So that was just a quick highlight of tertiary prevention. I'm just trying to be cognizant of the time here. As we go this way, it's better. So now let's talk about secondary prevention. This is where you are detecting early disease. So it's just starting, but you're hoping to find it early, perhaps before it's symptomatic, doing something about it and removing the person from the workplace. So I just have a couple slides on this. So this might be effective, and there is medical surveillance that does exist for work-related asthma. And as a specific example, you can look at the designated substances, and there's articulation of a process that you can do for those exposed to isocyanates. That is, do questionnaires and spirometry to identify early disease and hopefully do something about that person. Again, I'm not going to review all the literature, but there was a bit of a review article that reviewed 72 reports that looked at secondary prevention of asthma. So does it work to identify these people early? The bottom line is they don't know. So most of these reports actually didn't look at an outcome. They just sort of summarized the data. It theoretically should work. These type of diseases, like an asthma that's acute and has a clear medical outcome that we can measure, we should be able to identify people that are early in disease and then remove them from those exposures. And that's what this review was sort of alluding to, and you can read some of these recommendations. They sort of dovetail a little bit with the newer designated substance for isocyanates. So bottom line is secondary prevention should work for work-related asthma, so it's something that needs to be continued to be studied to see if it actually is effective, and something that needs to be continued to be applied to workplaces that potentially have sensitizers. Again, the problem falls back to recognition. So a lot of workplaces don't recognize that they have sensitizers or might not know that they're there. And then, of course, dealing with the gold standard here, that's primary prevention. So ideally, you never have this disease in the first place. We're not very good at treating it. We may be able to recognize it, but let's not have it occur in the first place. And that, of course, is this whole structure. And it would be a hygienist that would speak to this better. But it's all of these typical steps that we can walk through. And Lynn reviewed it with respect to the skin disease, and it's very analogous to this. I just wanted to highlight some of these particular challenges and successes, actually. So Gary's here in the room. This study just described work-related asthma in healthcare in Ontario. And there seemed to be lower rates than there were previously, and there was a suggestion or insinuation that this may be due to preventive strategies. So it just was a success story alluding to elimination of latex in the healthcare field. And this is a very similar one as well. I can't remember what country that was from, but it is possible to mitigate or eliminate or whatever method they might have done the sensitizing exposures, and there actually be a positive outcome of that. Some of the challenges of doing that, though, again, are recognition. So often workplaces will look at MSDS, won't they? Well, MSDS should be a perfect system for sensitizers. If there truly is something sensitizing in that environment, it should be clearly identified, and that's what the legislation says. We know, though, in practice that doesn't always work for a couple of reasons. For one, if the concentration is so low, it might not be listed. So might fall between the cracks. And secondly, unfortunately, it's not a perfect system. And again, Gary's sort of done some unpublished work in this regard, but this review article suggested as well. They're not perfect, so even exposures to isocyanates might not be indicated in the MSDS, so there are some egregious holes in some of this reporting system, so you can't completely rely on it. It just makes it difficult to identify things in the first place. And the other interesting thing, and this is always a bit of an eye-opener for the health and safety world, Regulation 833, of course this is the booklet that defines the OELs in the province, isn't it? And if we're using that as some sort of benchmark or standard to protect the workers, you need to understand it doesn't always work for sensitizing agents. That if I'm allergic to something, my threshold might be below a prescribed limit. And sensitization is one of those things that is very rare and very sort of idiosyncratic, that it's a personal type of thing. In other words, this regulation does not completely apply to sensitizers, and there needs to be some understanding that very low thresholds may cause asthma. So it's just another challenge in workplaces and in the health and safety world in preventing these things. So that was just a brief review. Again, it was just 15 minutes culled from, I don't know, 100 slides or something. But generally, just understand work-related asthma, it's not uncommon. And remember the denominator aspect as well, but unfortunately it's often under-recognized, and there are challenges across the different prevention levels in dealing with that.